Assalamu alaikum. Thank you very much for this nice introduction. And also I want to thank Sanofi for inviting me to highlight about very rare disease which can help you in the diagnosis of lysosomal storage disease. So if you see this slide, you will see a lot of symptoms and signs. And first things, commune differential, could be malignant hematology, could be metabolic causes, infectious causes. But also, what I want from you to consider the very rare disease like lysosomal storage disease. So, this is our objective. We'll talk about the ASMD, pathophysiology, subtype, symptom and signs of ASMD, and what is the similarity and difference between Gaucher and ASMD, and why we are considering parallel test with Gaucher, and how the symptom management. So, ASMD is acid sphingomyelase deficiency. It's known before as Niemann-Pick disease. They have three types, A and AB and B, and it's lysosomal storage disease. It's very rare disease. It's estimated around 0.4 to 0.6 in 100,000 people. It's affecting multi-systems like spleen, liver, lung, and also hematological. It's affecting also both male and female, and both children and adult. So the pathophysiology of ASMD, it's caused by pathogenic variant of gene ASMBD1, which coding for the enzyme, which acid sphingomyelase, which have a role in breaking down the phospholipid sphingomyelin, which is in lysosome. So deficiency of this enzyme can lead to accumulation of the sphingomyelin in the hepatocyte and monocyte macrophage system, which can cause progression and multi-system progression in the spleen and liver and lung and bone marrow. So how this disease is inherited? It's autosomal recessive. So if the parent is carrier, so we have for each pregnancy chance 25% affected and 25% carrier and 50% is normal. So very important to screen and educate the family about the disease. So as I mentioned before, they have three types, type A and overlap between type A and B, and type B. The onset of type A is in early infancy. It's rapid progression. It's affecting multi-organ, and they manifest with CNS manifestation. The life expectancy from 2 to 3 years. Regarding type AB, it's onset from infancy to childhood. It's slow progression comparing to type A. It's also manifested with multi-organs and CNS manifestation, and the life expectancy is childhood to mild adulthood. Type B, which is the most common type, the onset from infancy to adulthood, it's also slow progression and affecting multi-system, but here there is no any CNS manifestation, and the life expectation from childhood to late adulthood. And this is again showing the life expectancy. As you see, type A until 2 to 2 years, AB until 10 years, and type B until 35 years. And the most lead complication lead to death is liver disease and respiratory disease, and you'll find bleeding as one of the reasons of the disease is thrombocytopenia. And the failure to diagnose early of ASMD can lead to these complications. So what the suspected time? Usually there is delay in the diagnosis of the ASMD almost 5 years. And that's why early diagnosis can help the patient to manage the patient early and before the complication progress. So what is the symptoms of ASMD? As I mentioned before, they can present with a shortened breath and character of interstitial lung disease, can present with the splenomegaly, hepatomegaly, and also increasing in the liver enzyme, and also one character is hyperlipidemia. Also can present with GI symptoms, and in the hematological can present with thrombocytopenia and anemia. CNS, as I mentioned, it's present in the type A and type AB, can present with hypotonia, ataxia. One character in the ophthalmological and the ASMD in type A and B, it's present of cherry red macules. They also can present with a cardiac symptom, but it's very rare. Also, they can present with a skeletal, like bony pain, osteopenia, and osteoporosis. So here in this slide, you will find the most frequent presentation in the ASMD. You will find around 90% they can present with the splenomegaly, 70% they can present with hepatomegaly, and 80% can present with the interstitial lung disease, and 50% they can present with thrombocytopenia, and 75% they present with the GI symptoms. So if you have this symptom, you put your ASMD and lysosomal storage disease in your differential diagnosis. So as we mentioned, in the splenomegaly, they can present in 90%, and the most reason why spleen is involved because of infiltration by lipid-laden macrophage. So the patient they can present with abdominal pain, and also they have a risk to rupture of this spleen and cause bleeding. Hepatomegaly can present in 70% of the patient, and the reason is because of lipid accumulation in the hepatocyte. So they can present with abdominal pain, elevated in the liver enzyme, and elevated in lipid profile. And finally, they can progress to fibrosis and cirrhosis. Interstitial lung disease can present in 80% of the patient, and they present with a shorter breath, repeated chest infections, and they will have restricted pattern in the pulmonary function test. Hematological presentation, they can present 50% of thrombocytopenia, and also they can present with anemia, around 20 to 30%, especially in type AB and B. GI symptoms found in 75% is general symptoms, abdominal pain and vomiting and diarrhea, and that's also common in the type A. CNS manifestation, as I mentioned in the first slides, it present in the type A and type AB. It's account around 30%, and the patient they can present with development delay, peripheral neuropathy, psychiatric symptoms, hypotonia, and ataxia. And the other character, ocular abnormality, as you see in the pictures, they can present with molecular cherry red spots. So what's the similarity and difference between Gaucher and ASMD? So here in the pathophysiology, you will see in the left side, deficiency of acid sphingomyelin enzyme can lead to accumulation of sphingomyelin. In the Gaucher, we'll see that there's deficiency of glycocerebrosidase and lead to accumulation of ceramide in the system. So Gaucher and ASMD, it affects all children and adults, occur in all population. Both of them, the cause is deficient in the enzyme, and can also diagnose by measuring this enzyme. And also they can present with anemia, thrombocytopenia, hepatosplenomegaly, and also skeletal manifestation. Here we go to the types of Gaucher and ASMD. The more severe phenotype, type 2 in the Gaucher and type A in the ASMD. Both started onset in the early infancy. Both is progressive, affecting multi-organs, including the CNS manifestation and the life expectation until the 3 years. Intermediate phenotype in the Gaucher is type 3 and type AB in the ASMD. The onset from infancy to childhood, it's slower progression comparing to type A and type 2E. It's also affecting CNS and also affecting the skeletal manifestation. An attitude phenotype, type 1 in Gaucher and ASMD type B. The onset from infancy to adulthood, it is also slow progression. Both of them, they have no CNS manifestation, but also affecting the multi-organs. The character of Gaucher also is affecting the skeletal manifestation, but in the type B in the ASMD, there is no any skeletal manifestation. So what is the clinical feature for both? So they can do bone marrow infiltration, can cause hepatosplenomegaly, can cause portal hypertension, can cause lung disease and bone disease and CNS manifestation. But in the liver, cirrhosis and portal hypertension will be found in ASMD more than Gaucher. In the skeletal osteopenia, they can found in both, but osteonecrosis will found only in Gaucher. Interstitial lung disease will find more in ASMD, more than Gaucher. Laboratory cytopenia is more in Gaucher, more than ASMD. High liver enzyme you can find in both. Low HDL cholesterol also found in both. Hyperlipidemia in ASMD. And cardioprotective hypolipidemia in Gaucher disease. And this is a picture that can summarize the clinical signs and symptoms, the similarity and difference between ASMD and Gaucher disease. So, if you have these symptoms, hepatomegaly, splenomegaly, anemia, thrombocytopenia, you will consider as hematology malignancy, like acute leukemia, lymphoma, some cases multiple myeloma or MPN. And when you screen for this disease, some patient you will get negative for this disease. That's why we have to consider the lysosomal storage disease in your differential, ASD, ASMD, and Gaucher disease. So in the ASMD can be sometime overlap with Gaucher disease. That's why you are asking to do parallel test. So we can do parallel test detecting the enzyme in all patients suspected ASMD and Gaucher disease. As a guideline, recommend to do the parallel test. So, if you have a patient with splenomegaly and hepatomegaly, first, with the suggestion of ASMD in this septum interstitial lung disease, thrombocytopenia, low HDL, pathological fracture, test for ASMD. And if not, test for Gaucher disease if you don't have any symptom of, but even if the Gaucher disease is negative and the other cause is negative, again test for ASMD to rule out ASMD. So the test is, it's very easy. This is the card, we can do the test, and you will see here in the bottom there is Gaucher and ASD disease. Just what you need, just to put the drop of blood to test for the enzyme activity. And if one of the enzyme is low, they will confirm it by genetic test. Here, we'll just focus on what you need for this patient. You need multidisciplinary team to provide supportive care to help manage some of the symptoms. Like we need to maintain nutritional to control fluid retention, advise the patient to don't do any hard sport to avoid rupture of the spleen. If the patient have low oxygen, so we need a supplement of oxygen. Need Sometime intervention by ENT to control the bleeding, especially most of the patient present with epistaxis. Need day-to-day and life intervention and education support and physical therapy. So in summary, just what I need to consider is to consider the ASMD and the Gaucher disease in your differential and in the labs. So when you have these symptoms, test for confirmation and treat the patient if they suspected ASMD or Gaucher disease. Thank you very much.